70, almost 79. And so I just worry about someone 60 or below. Okay. Maybe you are not get used to the test style. And I think that the only 2 or 3 questions are really tricky. Then other part is tricky. So I hope you can improve in the next one. Thank you. Appreciate running out of that. So if you really have some difficulty, then you can talk to me. Maybe the way you study is not quite correct. A lot of students came to me and find out the wrong question, and they find out is they understand my talking but just cannot memorize or organize. Okay, and so if you have problem, you can talk to me, and you better have 2 or 3 classmates study together and have someone to ask you question, challenge you. Okay, and then you organize something. Okay. All right, so don't feel too bad if you are low, you still have a chance. Okay, but I would say most of you are doing good, doing very good. Okay. Now today we will finish chapter 20, and then we'll go to chapter 21. Last time I mentioned a little bit about hot sound. We had 2 major hot sounds, 1 and 2, and number 3 and 4 you don't need to worry about that. The 1 and the 2 is because the curls of the vowel. So the first hot sound sounds like a "l," and the second sounds "t," and it is the AV vowel curls, bicuspid, tricuspid. Second hot sound is semilunar vowel curls, coronary valve and alveolar valve. Okay. Now there's hard location right here, and that is on the top space on root number 4 here, apex. And where is put a sensor in particular location, I think this is the bigger one, is we know the light blue color here, that's tricuspid, and dark blue is bicuspid. And so we open the open direction. So we put a sensor a little bit low here. For bicuspid, we put a little bit low here. And the brown color here is alveolar valve. And the green color here is pulmonary valve. And so the way we put a sensor is my chest here. We know there's tricuspid, bicuspid, so put a little bit low. Tricuspid, bicuspid. Let's best listen to the first hot sound and it curves. Aorta go that way, so that's alveolar valve, and put it here. Pulmonary valve go that way, so put it here. That's best for second hot sound. Okay. But we are not experts, so don't worry much about the sound. The key point we want to know is what it happened. When we look at maybe this one sensing, we focus on left side, left atrium, blue color, small change of pressure. Don't worry about that. Look at the red color, left ventricle. That's one we focus. Okay. So the first we look at is AV valve curves, and in this case mean bicuspid valve. When it curls and then starting to pump the blood out, so the blood pressure increase. Okay, that the increase. Of course, at this time, after 20 milliseconds, seconds in the aorta pressure, aortic valve should be open, and so the blood is sent to aortic arch. And then here is a semilunar valve curve, aortic valve curves. Okay, so that will create second heart sound. Just focus on the curves, okay, the curves of bicuspid valve in this case. And in this case, an aortic valve curve. All right, so well, actually, when it curves, it's right side, left side all together. So we call AV valve curves. Is tricuspid and bicuspid, first heart sound. Now, if we put together, so I put a two star here. You look at the curves. Okay, when they open, you don't hear any sound. EKG and the cardiac muscle activity. And first, you look at this. The electric action potential is a little bit before this muscle activity. So right after QRS, that action potential is the place when the left AV valve curves. That means bicuspid valve curve create majorly the first heart sound. Okay. And when we had a second, we had a T wave, that's ventricular reanimation. When you look at this one, it's a ventricular systolic, pump the blood out, and the end of them, aortic valve close, and then create second heart sound. Okay, so for you to know is that's most important is right after QRS. Peak or QS wave, or right after T wave. And for the volume, I think we already mentioned last time. So here I summarize is first heart sound is after QRS complex, and second heart sound is after T wave. Okay. The location I just mentioned that. Now we go to the factors affect cardiac output. It could be due to the reflex, autonomic tone, epinephrine, or hormones, or diastolic volume, or systolic volume. We go first. The reflexes is by baroreceptor and the chemoreceptor, majorly controlled by baroreceptor. Baroreceptor means we have three locations. Is attack the pressure change. In the right and the left internal carotid artery, the corner we call internal carotid sinuses. In the aortic arch, we call aortic sinus. In the right atrium, we just call the right atrium baroreceptor. But the number one and number two use the same mechanism. When carotid artery sense the pressure increase, that means a lot of blood volume, pressure too high, or aortic arch. And when the feedback is through the reflex, it stretches this baroreceptor sent to the central nervous system, and activate parasympathetic means let it slow down, and then they release acetylcholine, and then there will be decreased heart rate, increased vessel dilation, blood collect in the blood vessel, and decrease the blood pressure. And so there's a negative feedback. It's very good mechanism. But in the right atrium, it's different story. The first carotid sinus, aortic sinus, it means blood up. And right atrium is blood in, sent back from superior vena cava, inferior vena cava. And so when blood pressure increase, the pressure increase in the right atrium, that means the return, blood return is greater than output. And so it will stimulate the receptor and trigger sympathetic activity. That means output is too slow, return is too much, so we had to compensate for that, and so they will increase heart rate. It's different from the first cardiac sinus and aortic sinus. It's up, and this one is in, okay? And so this one we call atrium reflex. It's covered by Dr. Bainbridge. Okay, so that's the name. But the key point is when you see the bottle, you see pressure, blood pressure change. The second is chemoreceptor. Chemo means chemical. That detect what? Hydrogen ion. And not directly control the cardiac output. It also located close to internal carotid artery. But they don't have a dry atrium. They had one in the brainstem, medulla oblongata. They also sense the hydrogen ion in the CSF for this oblongata. And for this aortic body and carotid body, we don't call sinus. Sinus is baroreceptor. This one called body. It sense hydrogen ion change. And the response is what? Increased respiratory rate. It controls the lung function, not control the heart. If the hydrogen ion is too much, then will increase the respiratory rate. It increase the rate, and so get rid of the CO2. Okay, and so that's not actually directly control cardiac output. Okay, so here I put cardiac center medulla oblongata. Okay. Another receptor is a cardiac center in the brainstem. When blood pressure low, we don't have enough oxygen, we have too much CO2, and so to increase heart rate, get rid of this waste and get in this oxygen. The other thing very easy is that sympathetic or parasympathetic. The release of the transmitter from sympathetic is norepinephrine or epinephrine, increase heart rate. Acetylcholine, that will decrease heart rate. You know this very well, right? And hormone circulation, in this case, is hormone, not a neurotransmitter. The same thing, okay? Epinephrine, norepinephrine, increase heart rate. Thyroid hormone, T4, T3 increase. Glucagon, because it increased the glucose, also increase stroke volume, so it's indirectly increase cardiac output. Then the ventricle holding how much blood called end-diastolic volume, they also affect. We will mention that later. Okay. Now, the thing I want to show you a little bit, our textbook show a little bit complicated. Okay, the sympathetic and parasympathetic, they all innervate the heart. So what's the difference? Okay, this thing is so easy. Parasympathetic, we're working on SA node, AB node. That's it, okay? And sympathetic usually cause contraction. Sympathetic will add SA node, AB node, the same thing. Plus, this one is the A, plus cardiac muscle. Okay, so that one will be the atrium. So sympathetic is a little bit strong. And this book you cannot see very well, but this one you can see that innervation they call then this brown color here, that from here, that's cardiac nerve, that would be sympathetic postganglion fiber. Okay, so that's the one they work on atrial one. But this figure is much easy, you know. This one is atrial. Okay, so sympathetic will control more place in the heart. Okay. If this one is the normal heartbeat, I think we can do this experiment, we isolate a heart in a frog and put in a petri dish, and then we add huge drop of acetylcholine, and then you can see it slow down the heart rate. The top here is normal, and we put no adrenaline or adrenaline will increase heart rate. Okay, that's sympathetic. All right. Now the number 4 factor is end diastolic volume. We had a principle we call Starling law, or we call Frank Starling principle. Starling is the teacher. Frank is the student. Okay, they discovered this. Easy to know is more blood in equal to more blood out. I mean, in the ventricle, if you feel a lot of volume in the blood, it will pump out more cardiac output. And so more blood in, that means more end diastolic volume, more EDV, and more cardiac output. And this EDV we call preload. Before the contraction, so we call preload. I will show you something here. Okay. So from the other textbook, they show you the inference for short volume, 3 major factors: preload, afterload, and contractility, meaning muscle activity. The first is the Frank Starling law of the heart. More muscle is stressed, more end diastolic volume, greater force for contraction. So more in and equal to more out. And that is the principle in the emergency room. The doctor, when the patient lost a lot of blood, first inject the fluid. Okay, if they cannot find the right type of blood, they inject normal saline. I think I mentioned before, and that's 0.9% sodium or that's saline. To make up this preload. Otherwise, the heart will slow beating and sometimes it may stop. Okay. So preload, we're talking about volume. So here you write a word here, volume, EDV, and diastolic volume. Afterload is the other thing. Is the pressure or tension the ventricle majorly left. Must produce to force open the semilunar valve, majorly aortic valve. And what I mean, I have to jump a little bit. Here is, okay. Preload means we close this semilunar valve and let the blood coming down from atrium through the tricuspid or bicuspid, and feel a lot of blood in the ventricle that will be preload. Okay. Then when they feel the maxima, all the 4 valves will close for a while, and then have to pump it out through the muscle contraction and open this aortic valve or semilunar valve. And how difficult to open the valve we call afterload. After we loading the blood to the maximum volume in the ventricle. So afterload is not talking about volume, talking about tension or pressure. How difficult to open the aortic valve. If someone has hypertension, it's very difficult to open it. Okay. And so go down to here. Afterload means amount of the pressure or tension created by semilunar valve, you put majorly aortic valve. Okay? And it affected by the continuous artery like aorta, the major artery. High blood pressure will create high afterload. Very difficult to open the valve. Okay. All right. The third factor is kind of constant, right? by available of iron or hormone or epinephrine or noradrenaline. So go back here. After all, will indirect affect the ESV. It is controlled by the tension. Okay, I would better to replace ESV with afterload. Okay, afterload means if we had less afterload, I mean very easy to open the active valve, and then that means after contraction, the systolic and systolic volume will be decreased because most of blood pump out, and that means stroke volume increase. That means cardiac output increase. So that's what we want. Okay, what we want is increase EDV preload, decrease afterload. That's the active valve very easy to open. Number two situation is the one we don't want it. If the afterload is increased, very difficult to open the valve, active valve, then after systolic, the volume is still a lot there, we pump out less. That means stroke less, that means cardiac output less. So the way we want is less afterload, less ESV, and more cardiac output. Okay? So for here, you put volume, and we want increased EDV. And here you put afterload, we want less ESV, less afterload, less afterload. Okay? And so put it together, cardiac output, the equation is heart rate times stroke volume. And heart rate is affected by sympathetic parasympathetic hormone. And stroke volume is controlled by EDV or ESV. Okay. And then if we put a little bit more complicated, heart rate times stroke volume. If you don't stroke volume, you have EDV minus ESV stroke volume, right? This one too complicated. Don't worry about it. That means stroke volume is affected by what? Preload and by afterload. Okay. And the other thing, don't worry too much of it. Some hormone will affect both of them. Major thing you have to know is this one, or simply this one. I think this figure is very clear, and you put preload as here, and afterload is the pressure. Okay. Oh, this one made everybody headache. Okay, don't worry about it. Now, clinical term CAD means coronary artery disease. I mean the blood vessel supply the cardiac muscle. Two terms different. Heart attack means a blockage of coronary circulation during arteries. Okay, and they will cause death of some cardiac muscle and maybe stop beating and a person can die. Stroke means bleeding in the brain. Okay, it's not related to the heart. Okay, it's in the brain, and it's because the blood clotting and pressure too high and breaking the blood vessel and cause the bleeding, that blood clots or damage to the neuron in the brain. Okay, so these two terms different. Okay, the other two terms, bradycardia and tachycardia, slow heart rate or fast heart rate. And cardiac arrest means stop, suddenly stop. Cessation means stop. Okay, if the EDV is too small. Bradycardia and tachycardia. That one, it looks like this one. Normal heart rate, and this one is, don't worry about this one. Just say tachycardia, fast, heartbeat fast. Bradycardia, slow down. Okay. And if you cannot memorize this term, just say, okay, oh, tachy, it sounds like touch. And then you watch a lot of football, right? Touchdown, okay, you have to run very fast, okay, fast heart rate. Bradycardia, brady is about broken heart, okay, so. Okay, all right. The other way I make here is this cardiac arrest. Sometimes the heart stops beating, and some problem is because SA node or AV node have problem. They cannot send out normal pulse or action potential. And how the doctor do it? Okay, we put a battery we call pacemaker, artificial battery, and just bury inside the chest, just under the skin. And this one is a superior vena cava. Okay, this is a Aquarian vein. Make a very easy surgery and then circle here, prevent bleeding, and put one electrode in the right atrium, and the other electrode in the right ventricle, and they can send out. You can adjust, let's say 70 beats, 70 pulse a minute. Then they can treat this cardiac arrest or someone's irregular beating, okay, or here is the one. Okay. And it's very easy surgery. Probably the doctor can just take about 20 minutes and do this. The other thing is the heart disease is because the narrow down of its diameter, because the lipid or cholesterol deposit here, and it caused the blockage. In this case, is anterior interventricular artery, and cardiac muscle, and this area will damage and will lost the function. And so, how to prevent this? The first thing is the patient can sense is the chest pain. Angina is pain. Pectoris is chest pain, because short of oxygen, and usually start from the center and spread to left arm. Okay. And that can happen maybe 2 years before the heart attack. And then slowly, if not any treatment, the blood clot can happen in any kind, any artery there. And if we found this one, how we do it, we can put a TBA, I mentioned that dissolve this clotting. Or we can put an angioplastic balloon or a stent technique, I'll mention that later. And if nothing happens, we don't have any treatment, and finally they will completely block, and the cardiac muscle will die, and we call myocardial infarction, MI. Okay, so it's reverse. Okay, starting from angina pectoris, and then blockage, blood clotting in the artery, and then myocardial infarction. Okay, so now we talk a little bit more about this second one. If we find this blockage in the chapter 19, I mentioned that if we have tissue plasminogen activator, then if we have available thrombin, and we can inject, and then they can change this plasminogen to plasmin. Plasmin is the active one. They can dissolve the fibrin to individual amino acid. Okay. But this one is timing very important. It should be 3, maybe couple hours, 3 hours after heart attack. And if the clot, the fibrin is very big, already happened after 1 day or 2 days, it's too late to treat. MI, when it happens, if you working in the ER, when the patient is sent in, the doctor will do blood test first. And what they test enzyme in the blood. If they have this cardiac troponin, T, troponin, I, and we call this creatine phosphokinase. Phosphokinase could be CPK could be MP, the type B or type A, the one there. All these three majorly is troponin T and troponin R. Okay, if they increase, I mean it is 100% sure as heart attack. Okay, this heart attack will the death rate will happen even higher in people under 50 years old. Okay? And some of a quarter of them will die right away. And so how we treat this? The first is prevent. The risk factor like smoking, high blood pressure, high cholesterol, or stress, or less physical activity. Okay? Even you are young, you can pay attention to this. Okay? And if your father or your uncle had all this kind of things, you have to tell them, okay, stop smoking or high cholesterol, they take the medicine. Then if they find this one, then how they do this? I just show you something easy. Is put something to block this sympathetic stimulation. That means make it vasodilation, reduce the blood pressure first. This one, don't worry about this. This you are not doctor here. The first reduce the blood pressure. Okay. And if that happens, we just try to dissolve the clot first and give it more oxygen. But before that, actually they have some symptoms, chest pain, and we put a balloon or stem angioplasty. That's what it means. I should go this first. All right. Angioplastic with a balloon. We insert a catheter to the blockage. In this case is right corner artery. And here is the blockage. And I mean it's partially, not 100%, so it's still curable. And then we inject the air balloon there to extend it, and it will reduce this blockage from this maybe 60% down to maybe 20%. And so blood can go through. Okay. And how they do this? They do this by inject to big artery, here femoral artery here, and insert a catheter and all the way up to LT arch, and from last that maybe you know above the LT valve had two holes, and they go to the right side. They go to the right corner artery. Okay. The other technique is they are not from the leg here. They're from the arm here. On the big arm, they can put a stroke, but it's put into the artery, not into the vein. Okay. Because we want to put a catheter up to alta here, and if this side blocked, and then they would insert here. If the anterior interventricular blockage, they go inside this section. And so everything this kind of technique is under the under this the TV there, and doctor have to train it. Okay, they probably need to train about 2 or 3 years to do this kind of technique. And after they say this one broke, and then they inject something, they put catheter there. The first is inject some dial there. This one just by X-ray, and they can see the right artery is narrow here. Okay, or they can put color. This one show you the right side healthy person, right coronary artery, left coronary artery, and this one, see, people had this kind of partially blocked, maybe 90%. And you can see this side, not see very well the artery. That means that some cell maybe already died. And we call this, they all call this angioimine blood vessel. Okay? graph. But this one we can color in hand. And after that, if the blockage is not too big, they can do this blowing technique or stain. Stain even better with the metal one, and stain even bigger, stronger, and they can last longer. Okay, they can from this blockage, big blockage to small. And how long can last? Okay, they say probably 8 or to 10 years. And after that, the patient can take the heparin, or we call blood thinner, to prevent the blood clotting in this side. Okay. All right, that is the way I say the caster stain. And what is it? Just give you an idea, because we are not doctor yet, but we test this. And if the blockage size is more than 95%, and how we do it? We do it coronary artery bypass surgery, and we cut a vein from the patient and implant to one L-top, and the one is below the blockage site. Like this one here in the ventricular, they had a blockage here. They made a suture below it or L-top. And L-top sometimes very difficult to do it. They do the branches from this L-top arch, from a little bit smaller artery, and then connect. And this patient has 3 blockage. With this one, okay. Why they put blue color and the red color? Usually they use a vein, and some doctors use a small artery, cut it from the hand here, that's radial or ulnar artery. But it's dangerous because you cut it out and it causes a lot of bleeding. So most of the cases they use the vein. Congestive heart failure. You have usually in the left side is because the valve got damaged and the blood cannot pump out. Let me just write down here. If that is part here, like this. Ventricular septum, and if the valve here is very difficult to pump out the L to the L-top, the blood difficult in the left ventricle, and the compensatory response is what? Sometimes the valve have problem. It pumps to the left atrium, and the muscle enlarge. So the first is enlarge of cardiac muscle. And the blood will coming out to here, and this one will go back to right to the pulmonary vein, and go back to lung, right lung or left lung. And so the fluid accumulate in the lung, and we call pulmonary edema. It should be not blood. Okay, and finally, the left ventricle will become loose and enlarge, and finally stop bleeding, and so we call heart failure. And usually happen in left side because the left side was systemic circulation, and usually cause the bicuspid valve damage. Okay, it also can happen in the right side, but a little bit small percentage, and cause the peripheral edema, meaning both legs enlarge. And so if you see a patient or someone in your family, the old person, if the both legs enlarge that means blood cannot return. Okay, that's heart problem. Major is heart problem. They cannot if just one side, maybe something else. If both sides enlarge, that's heart problem. Okay. Risk factor for heart disease. We all know this very well, right? Cholesterol, blood pressure, cigarette smoking, obesity, lack of exercise. Yeah, that's major factor. And the other factor is diabetes, or male is greater than female, okay? Or fibrinogen too high. Okay. Then we have to know this cholesterol. We had a good cholesterol and bad cholesterol. The good means high density lipoprotein. This one I will cover more detail in chapter 25. Okay, but I just give you an idea. Total cholesterol, your H should be under 180 milligram per DL. Bad cholesterol, the low density should be low, 100. High density HDL, good cholesterol should be greater than 40. Triglycerides, part of oil, should be lower. It's very similar, lower than 180. Now we had a equation, total cholesterol. Actually, how we calculate is all the LDL plus HDL and triglyceride times 0.2, or triglyceride divided by 5. Okay? We estimate all your there, and roughly something like that. Okay? And the thing I want to tell you is, for you ladies, okay, you have estrogen, female sex hormone. When you are young, your HDL always high, 40 or 50 or 60. I saw someone 70. So your heart got attacked. Okay, so the heart disease is relatively very low in the ladies, less than 50 years old. But after menopause, you lost this estrogen. You also lost this HDL protection. And how is good for exercise? Everything is good, okay? Increase cardiac output, increase HDL. That's the only way you can do this. Not by food, by exercise. And decrease triglyceride. Improve the lung function. Decrease the blood pressure. And lost your weight. So everything is good, okay? You got it, okay? 3-5 times per week. At least, I would say 30 minutes every day. So exercise, okay? That's the way protect your heart. Oh, this one I already showed it. I will continue for a while then. Let's see. For the chapter 21, I'm not according to the textbook order. I just show you the difference between the artery and the vein. Then I go to the anatomy first, okay? And so it's a little bit different from the textbook. And the first thing I just wanted to know is in the blood vessel we have 3 layers, and in this one we call tunica, new layer. Intima, media, and external. And from here you know it's inside, middle, and outside. Okay? And artery usually strong, smooth muscle, so usually round shape, even without the blood inside. And the vein, without the blood, it cannot sustain the shape, and so sometimes it's irregular shape. They have more muscle in the artery and less muscle in the vein. Under the microscope, you will see that artery has this elastic fiber here, and you can see a lot of curve here. Okay. Let me show this one. Vein here, and that's artery. Right? You can see that in the CNC a lot of curves here. And so I just make a table to compare them. Inside artery, they do have this internal elastic membrane, so they curve, and they have more muscle. They both have muscle, and they also have external elastic membrane for artery only. So that's a major difference. Yeah, I think yeah, that's the major difference. And the other thing is very tiny thing in this cannot see. Don't worry about it, people. And not all the blood vessel you can see all the 3 days. In this tiny one, arterial or the capillary, you cannot see all of them. The circulation through the whole body, because systemic circulation, to the lung we call pulmonary circulation, and to the lung just reverse. The pulmonary artery is carry the oxygen in the blood, right? And pulmonary vein is carry fresh oxygen. And if you are old textbook, actually from the liver, they miss one. The artery also show fresh oxygen to the liver. And this one, I think they change one. Okay, this all this artery fresh oxygen, that is all this vein sent back. Okay. Only thing I want to know is systemic circulation accounts for 84% of total blood volume, and pulmonary only accounts for 9%, and we have the other is in the heart. All right, I think that's it. I'll take a break, and then we come back. Then the next one will be anatomy.